Hi, my name is Dr. Karina Yu, and I'll be explaining anesthesiology preoperative patient satisfaction, surveys on the same day before surgery. Patient satisfaction scores have become increasingly important in healthcare. Value is driven by perceptions of quality and linked to revenue and compensation. Unfortunately, patient satisfaction surveys completed after surgery or an inpatient stay may relate to the entirety of the patient experience or the surgical outcome itself. Pain and nausea control may be related to pre-existing conditions in the nature and duration of the surgery, such as a small bowel obstruction. Patients may not appreciate the role of the anesthesiologist or the members of the anesthesia care team. Many doctors' offices include a patient satisfaction survey at the end of their visit. The challenge for anesthesiologists is that many patients may not see an anesthesiologist in a preoperative clinic prior to the day of their surgery. So if we're not able to assess our patients before the day of the surgery and results are skewed after surgery, how can we assess our value during the few minutes of time that we have face-to-face with our patients? This quality improvement project demonstrated the ability to collect patient satisfaction surveys on the same day of surgery after the pre-anesthetic visit for the first cases of the day. The goal was to determine baseline patient satisfaction scores for 1 year, post-anesthesia care team signs in the preoperative rooms, and reassess for a subsequent year. This was especially important because certified anesthesiologist assistants gained licensure in the state of Indiana in 2016, and Indiana University started the 12th anesthesiologist assistant school in 2017. In addition, there were about 80 anesthesiology residents in our program with new physicians every July. The goal was for patients to know the training and qualifications of the members of the anesthesia care team and to appreciate that there would always be an anesthesiologist who would serve as director of that team. 7 of the survey questions were taken verbatim from the Surgery Hospital Consumer Assessment of Healthcare Provider and System, or HCAHPS, surveys. Question 8 was altered for verb tense, question 9 was altered to include the anesthesia care team, and question 10 was altered to include the preoperative area. Question 7 was taken from the EVAN-G/EVAN-LR questionnaire and adapted for the anesthesia care team. IRB exemption was obtained to administer the survey. Voluntary demographic data, including level of education, overall health rating, number of prior surgeries, and race were also collected. We managed to collect 452 surveys from November 2018 through November 2019. We then put up our anesthesia care team signs in the preoperative area and collected an additional 18 surveys before we terminated the study due to the coronavirus pandemic and cancellation of elective surgeries. The survey itself was only performed on patients who were the first case of the day, non-inpatient status, and seen by both members of the anesthesia care team. Only planned general anesthetics were evaluated, and patients without mental capacity were excluded. The overall results demonstrated generally high scores between 2.6 to 2.9, where 2 is satisfied and 3 is very satisfied. This is seen in prior studies. The surgery start time was not delayed on account of the survey administration, so there is a collection bias. The demographic data demonstrated significance for education level and race in a few of the questions. Patients with greater education were more able to ask the questions they wanted. Patients with greater education also had a better understanding of the role the anesthesiologist plays in the surgery and were more satisfied with their anesthetic care in the preoperative area. Health status and number of prior surgeries did not demonstrate a trend in satisfaction scores. African American patients were less satisfied than other races in questions 6, 8, 9, and 10, but this result was primarily due to 2 of the 24 patient responses obtained. As outliers, these scores would benefit from root cause analysis for underlying causes. The survey questions Cronbach's alpha score was 0.98, Kendall's tau coefficient was 0.63 with a p-value of less than 0.0001, and a Pearson's R correlation coefficient of greater than 0.86 that categorized into 2 different groups of questions. This suggests we could have obtained the same overall patient satisfaction scores with just 2 questions rather than 11. Despite the inability of the study to evaluate the effect of the anesthesia care team definition sign on patient satisfaction scores, we successfully demonstrated that surveys can be collected preoperatively on the day of surgery, decreasing the confounding factors related to surgery and patient outcome as we look at anesthesia quality. These surveys can help identify areas for future improvement and reinforce the importance of building patient relationship and educating them about the role of the anesthesia care team in the pre-anesthetic visit.